Thank you all for joining us today for our virtual Coffee with the Experts. Today's focus is on vulvovaginal conditions and the menopause. I am Dr. Hope Haefner. I will be moderating today's session. I'm a past president of the ISSVD and a professor at the University of Michigan Medicine Center. We're in Ann Arbor, Michigan. Today, we are going to discuss amongst ourselves the many challenges and issues we face when diagnosing and treating vulvovaginal symptoms of menopause. Before we do that, I'd like to invite you to join the ISSVD if you are not already a member. The ISSVD is the premier society for anyone wishing to further their knowledge and take an active role in improving women's health globally. The ISSVD is an international society with goals of promoting international communication, which we have just recently done with the publication of recommendations for the diagnosis and treatment of vaginitis, of which the members of today's panel took a part. A QR code will be available to download during this webinar. To view it on our website, go to www.issvd.org. We also work to establish international agreement on terminology and definitions to promote clinical investigation, basic research, and dissemination of knowledge in the field of vulvovaginal disease. As a member, you'll gain access to many, many benefits, most importantly, the opportunity to network with those significantly involved in the advancement of knowledge in this area. We do have an extremely active email listserv where you can get immediate answers to your pressing questions from other members. We are constantly updating our image archive and have a large resource library. Additionally, we have newsletters, frequent live events, and online events like this one, as well as online learning websites. This webinar is part of our Road to the Biennial, which is the 27th Biennial Conference on Diseases of the Vulva and Vagina. This live event will be held in Chicago, Illinois in the United States from September 7th through September 9th, 2023. Be sure to visit our website at www.issvd.org to register and join us. We have 2 networking events planned in addition to an amazing scientific program. Now I'd like to introduce you to my colleagues for today's session. Dr. Emily Delpero is an assistant professor in the Department of Obstetrics and Gynecology, University of Ottawa in Canada. Dr. Martha Goetsch is an emeritus assistant professor in the Department of OB-GYN at Oregon Health and Science University. She also received a Master's of Public Health at the University of California in Berkeley. Dr. Melissa Mauskar is an associate professor in the Department of Dermatology and the Department of Obstetrics and Gynecology at the University of Texas Southwestern Medical Center. And last but not least, Dr. Pedro Baptista. He is head of the lower general tract unit of Centro Hospitalar de São João, Porto, Portugal. And of utmost importance, he is the current Secretary General of the ISSVD. To all of the panelists, please feel free to offer your opinion throughout the discussion in this next hour. Also, to those of you listening, there will be time at the end of this session for you to type in questions for us to answer. So let's begin. Vulvovaginal conditions that affect women in the menopause are conditions that women should not have to suffer from. We will be discussing genital urinary syndrome of menopause affecting the vulva and the vagina, previously termed vulvovaginal atrophy, with also having brief discussions at the end on vulvar lichen sclerosis and vulvovaginal lichen planus. Dr. Goetsch, let's start with a 56-year-old woman that comes to your office complaining of vulvovaginal menopausal symptoms. She wants to discuss treatments for her dyspareunia in particular. Where does postmenopausal dyspareunia hurt the most?
Thank you, Hope. I'm glad to be here on the panel. This is such a common complaint, and it's been framed as an atrophy problem, but the whole genitourinary tract develops atrophy, but there's only a much smaller area that is actually quite tender when you really break down the exam to try to specify areas. And the vestibule has, I think, a very unique response to lack of estrogen. So the vestibule turns out to be the place that causes the pain. And the vagina itself is rarely significantly tender if you do the similar kind of light touch or whatever. So it feels like all these years, the appearance of atrophy and the fact that it hurts with vaginal penetration has meant that people assume it's a vaginal pain when really it's the vestibule.
And are you using a cotton swab or digital insertion for diagnosing this?
Well, yeah, you can. I always use the swab. If a patient comes in saying she has pain with sex, well, actually, to back up, many times women will use the same term that the medical field has used, which is dryness. That I have vaginal dryness. So, number one, they assume it's the vagina. Number two, dryness is the first sensation, but it actually, my first question then is it dryness or is it actually pain? And almost always by the time they're coming in for help, it's pain. It's not, it does feel dry, but of course, lubricant should take care of dryness. It does take care of dryness temporarily. So, yes, then the touch test is very important. And the way I use the swab is to use a light rolling touch. I don't even swipe, and I definitely don't poke because this condition is in the mucosa. And what we know now is that it's a stimulated situation of too many pain nerve endings. So the light rolling touch will allow you to just check, and you have to be right next to the hymen. That's where it's the worst. And it's only, it's a narrow zone, the vestibule. I actually, my comment all these many years has been to patients, these are the 2 square inches that wreck your life because it's just a small zone. And that's why it's avoided everybody's notice for all these decades. So yeah, the touch test is very important. You can map out the entire vestibule, just rolling slightly and asking them. I use a 1 to 3, 0, 1, 2, 3 pain scale. You don't have to go to 1 to 10 because it's either good or scratchy or ow, ow, ow. So yeah.
So what are your first line treatments for vulvovaginal atrophy?
Well, I'm not concerned about the atrophy, but I'm wanting to deal with the pain. So I generally ask patients whether they have general menopausal symptoms because I am an advocate for systemic estrogen when that is appropriate and when the patient feels open to that. And so estrogen of some kind is what is the treatment for the vestibule pain. And it takes a while. I mean, atrophy you can correct in a matter of 10 days, 2 weeks in terms of the situation of the vaginal maturation. So the problem of the pain has developed over a slower time and it takes longer to correct. And what I just finished was a study of women who can use estrogen, and I had them using estrogen cream solely to the vestibule every night for 90 days. And then I would see them intermittently, but they also would check. A lot of them weren't having sex because it was a study specifically of pain with sex, but they were using tampons to twice a week check whether they could tell that the estrogen was improving things. And so ultimately, it was was a high proportion of women. I think it was 80% who got significantly better over the 3 months, but it did take time because, again, I think it's a nerve problem, not an atrophy problem that causes the pain.
Dr. Delpero. Oh, go ahead, Pedro.
I was just wondering, because we've been repeating over time that the number of estrogen receptors in the vestibule is much lower than in the vagina. How do we reconciliate these concepts that you actually are getting a good response just from treating the vestibule, and on the other hand, we've been saying that the number of receptors is low? Do you have any theory on that?
Well, actually, I would probably, I'm not sure I know the literature that says it's lower. But the thing is that there are hardly any nerves that penetrate to the epithelium in the vagina. Yeah. There are tons of nerves that come to the epithelium in the vestibule. So, yeah, and I feel like it originates as a problem postpartum. I think nature has realized that if a woman has just had a baby, it would be good to have some kind of contraception so she doesn't get pregnant right away. And before the advent of modern medicine, contraception, pain was a pretty good contraceptive. So then, of course, the same programming, cellular programming, exists in the vestibule. So then with menopause, the low estrogen means, oh yeah, I'm supposed to grow more nerves. So, and those can slowly increase over time, which I think explains why it is a progressive pain problem, and it takes a long time to correct it. And the doses that the FDA has authorized aren't sufficient for anything but perhaps mild and early problems, in my opinion.
Go ahead.
I feel like I'm remembering that I think the estrogen receptor alpha is actually lower in lichen sclerosis on the vulva, but I'll have to double check that. But I think in lichen sclerosis, there was a couple studies looking at the differences, and it was especially in the fibromuscular layer. So I think below the epidermis, but I have to look back at those because it's very interesting thinking about how those, interplay with each other.
Yeah, and we did a study of premenopausal vestibule tissues biopsies, and there was receptor alpha but not beta, which is interesting. But what has been found in the vagina is there's alpha and beta prior to menopause, but after menopause there's no beta. So there's still more to learn, but definitely the vestibule responds to estrogen.
I do think it's important to go back to history. It was 1958 that Herman Krantz did a study looking at the number of nerve fibers in the vagina versus the vestibule. And there were many more nerve fibers in the vestibule. So Martha, you kind of mentioned you thought it was nerve fiber as part of the etiology, and that goes along with that. Mm-hmm. Well, let's move on. Dr. Delpero, let me change the scenario. Now you have a 56-year-old woman who has breast cancer history. She was estrogen as well as progesterone receptor positive, and she comes to your office complaining of vulvovaginal menopausal symptoms, and she wants you to discuss treatments to cure her. What are some non-hormonal treatments you might recommend?
So the assessment and the approach in this situation still is very much the same as a person without breast cancer. So it depends on their symptoms. Some people don't have the day-to-day genital symptoms or the urinary symptoms, and their issue is mostly dyspareunia. Sometimes people span the gamut of troubles on a day-to-day basis, and they're quite severely affected. So there really is a spectrum that I do see even within the breast cancer population. So in general, the talk after exam, and that I think that it is atrophy or genital urinary syndrome of menopause, the approach is very much a talk about vulvar hygiene in general, screening and avoiding for contact irritants, and some good counseling around using day-to-day moisturizers or sexual lubricants, depending on what the issue is. And making the distinction that a moisturizer is something that someone can use 2 or 3 times a week, whether or not they're having penetrative intercourse or having sexual activity of any kind, and that a lubricant can be used in particular around penetration or around sexual intimacy. So in general, the the moisturizers that we use to start off with are non-hormonal, so things that are hyaluronic acid based with vitamin E. There's some small evidence also for an oil and water emulsion that isn't available in Canada, so I haven't used it, but I think it's made by a company called Vagisan. In general, when it comes to sexual lubrication, the silicone-based lubricants seem to stand out in breast cancer survivors. And of course, there's also a discussion about layering in pelvic floor physiotherapy because of the vaginismus and pelvic floor dysfunction that can evolve with the ongoing discomfort they feel on a day-to-day basis and with penetration as a provocation.
What did you say the name of that product was?
I think it's a small pilot study, and it was called it was made by Vagisan, or when I looked at the methods, Vagisan had made this oil and water emulsion.
Okay.
That was used at the vestibule in particular for moisturizer.
I just want to clarify for a second. I thought you'd said Vagisil, and some Vagisil has
Oh,
benzocaine
no,
in it.
no.
My nemesis.
I have a big sign in my office being like, okay, speed walk past the Vagisil. We don't use Vagisil.
Vagisil will make you ill, and benzocaine will bring you pain.
Exactly. Yeah. So thanks for highlighting that. No, I did not say Vagisil.
Phew.
But trying to get someone off of it is so hard. You have to bring them back like every week, or I, sometimes have to give them, the topical lidocaine or the oral gabapentin to help with the burning, and then see them back regularly and just try to convince them we can get them off of it.
So what about this patient and topical estrogen?
So in general, it is a question that comes up because, estrogen and its association with breast cancer is very closely linked in the media. So usually once you've worked your way through the approach of non-hormonal management therapies, including what I've just mentioned, vaginal estrogen, or newly released in Canada at least, is topical progesterone, comes up for discussion. Breast cancer writ large is not a contraindication to local hormone therapy. Overall, we know that at baseline, using topical estrogen doesn't increase the risk for breast cancer in patients without a history. But where the discussion becomes more nuanced is patients on adjuvant endocrine therapy. So in this particular case, this patient is estrogen progesterone receptor positive, and chances are she has either been prescribed tamoxifen after her treatment has been completed, or an aromatase inhibitor. And those two molecules work differently. So tamoxifen is a SERM, which is sort of an estrogen agonist and antagonist, and behaves like estrogen in some parts of the body and blocks estrogen in other parts of the body. So it essentially works on the breast by antagonizing the estrogen receptor in the breast, and thereby reducing risk of recurrence. Now, an aromatase inhibitor is different. If you Google a quick steroid pathway, if you go back to your medical school days, the aromatase inhibitor is how testosterones, or DHEA or progesterone, make its way through the pathway to become estrogens in the body. So you block the aromatase inhibitor, or the aromatase enzyme, if you block the aromatase enzyme, which is actually found all over the body, not just in the ovaries, but in the fat cells, the liver, the brain, you don't get synthesis of estrogen, and people's estrogen levels are actually quite low, and they're lower than the average postmenopausal person. So in a person with breast cancer who is on tamoxifen, I say to myself, okay, so the oncologist actually doesn't mind if a person is postmenopausal and has postmenopausal circulating levels of estrogen. They're on tamoxifen, so the tamoxifen is blocking the estrogen effect on the breast, and I can use local hormone therapy without being that concerned. We actually have good safety evidence that in patients on tamoxifen, local estrogen does not increase the risk of recurrence. And also we do have evidence that shows that local estrogen in low doses doesn't increase circulating levels of estrogen in postmenopausal women above their usual norms. Now, in aromatase inhibitor, patients on aromatase inhibitors, that discussion becomes a bit more nuanced because the evidence is a bit conflicting. But in this case, a patient on an aromatase inhibitor, I go, okay, this patient's oncologist does not want this patient to even have the regular circulating levels of estrogen that are normal in a postmenopausal patient. They want them even lower. And so I approach this discussion with a bit of caution. We do have, there was a study released last year that did show, it was a Danish registry study looking at patients on breast cancer survivors who had been prescribed either systemic menopausal hormone therapy or local vaginal estrogen therapy, which did not overall show any risk of recurrence or mortality in breast cancer as an umbrella. but did show, interestingly, an increased risk of recurrence in patients who were on aromatase inhibitors and had vaginal estrogen therapy on board. Now, these results are a bit controversial because they weren't able to show an increased risk of recurrence in patients on systemic hormone therapy, which doesn't make much sense. But I do talk to my patients about the fact that about this study and that it can increase the risk of recurrence based on this study. That said, if someone is so affected day to day, which they can be, that they're thinking about coming off the aromatase inhibitor entirely or changing their adjuvant therapy because they're so impacted, I think layering in a local estrogen or a local hormone of some kind that potentially allows them to continue on the aromatase inhibitor and achieve those benefits and reduction of risk of recurrence for breast cancer can really be quite beneficial. So that's a very long-winded answer to say that it's a really nuanced discussion. It really depends on the patient sitting before me. It depends on their breast cancer journey and their discussion with the oncologist. But the bottom line being that breast cancer in and of itself is not a contraindication to local estrogen. And once you've worked your way through the non-hormonal options, can be used with a bit more caution in patients who are specifically on the aromatase inhibitor as their adjuvant endocrine therapy.
I'd like to throw another angle in, and that is that topical lidocaine is extremely effective for women who have breast cancer and who have dyspareunia. And a study I did 10 years ago taught a whole cadre of 50 breast cancer survivors to use local topical 4% lidocaine for 3 minutes before they wanted to have penetration. And the average was within 3 trials of that, they figured out just where to put it. And 95% of them were having completely comfortable intercourse whenever they wanted it, with a silicone lubricant, of course, at the conclusion of the 3-month study. And then the other thing was this recent study I did with the vestibular estrogen, the absorbed estrogen, serum estrogen levels, the median did not rise above the expected postmenopausal levels, like it was below 10. The thing is that we were actually just using an immunoassay, and virtually half of the blood samples were below 5. So our numbers are sort of pushed upwards a little bit because we didn't know the lowest value of what was, but it seems as though possibly the vestibule is a safer location, plus it's the one that's painful compared to vaginal estrogen absorption levels. So that needs more.
Yeah. And if you were to use even just like a cream to the vestibule, just the vestibule, like what you were saying, you're not inserting it internally. And I know we talk about systemic absorption. And firstly, the estradiol assays that we use are a bit unreliable. And it depends on the study that you're looking at. But when patients report systemic symptoms like bloating and cramping after starting vaginal estrogen, it does make me suspicious that there is some small amount of absorption. But if you just have it to the vestibule, for sure, that's a much, much lower dose of estrogen that you're delivering, and you're getting it right to the area that is causing the problems.
I have a couple questions.
Can I add a comment, if possible? We have, I don't think you have it in North America. We have the option to use estriol over estradiol, which seems to be an advantage in terms of breast tissue. And I'd like to hear your
Pedro?
comment. Yes.
Pedro, we can in the US use that, but it has to be made by a compounding pharmacist.
Okay.
Yeah, same.
Okay.
It's compounded, though. I'm curious to hear you say that and like to hear you say more, because I haven't used estriol in this context.
We have it available commercially in ultra low doses. That's the lowest dose we have. It's very effective. The formulation we have available includes it's estriol plus lactobacillus, which I don't think adds anything to it, but commercially it's an interesting concept. It indeed works quite well, probably due to the estriol. I don't think you would need a probiotic in there. My other comment, I tend to, when I put women using local estrogens, I tend to say them, as long as you're doing well, use it until you are 120 years old. these women with breast cancer are the group in which I tell them we are going to use it for maybe 8 weeks. And then if you're doing okay, we will stop and we might resume it later if needed. If they indeed resume intercourse, they will probably won't need it that soon. I know it's a fact that the levels might rise a little at the beginning, but it seems to be a safer option. I don't know what you do in your daily practice. Do you agree with this, or do you do it differently?
I modify according to what the patient is comfortable with too. I think that's a great approach, to use it episodically until they have some relief and minimizing the amount of continuous estrogen that they're exposed to. I don't think it's been studied though in that regimen.
No.
But I think that's a bit artful to do.
But I think it's hard sometimes with these patients is that, in their mind, like you mentioned in the media, it's so ingrained that like, oh, I have estrogen positive breast cancer, all estrogen bad. And so I think having those initial discussions, but then also letting them know, I often will reach out to their oncologist and just let them know like, hey, we're going to work as a team and don't worry, I'm not going to do anything, to throw things off. But when you're miserable, as you mentioned, we survived something, you survived cancer. Let's make sure that we can enjoy the time that we have, and phrasing it that way and getting them to come on board with that local treatment. I have two more curiosities with you guys. With the lidocaine, before sex, are they still able to orgasm? I mean, I think as long as they probably don't get it up top, and you teach them the proper place to put it, I would think they maybe still would be able to.
Yeah, definitely they can. Yes. In fact, that I was asking the patients whether they had improvement in orgasms and interest and libido over time, and 49% of them said yes, and 54% regarding the libido. So, and in fact, we may get to this, but the question of how does estrogen help orgasm quality? But I think in terms of the lidocaine, no, what happens is that it simply numbs that noxious, stingy, horrible sensation in that small little zone, and they can feel touch deeper. The deeper pain sensors, for instance, people have worried, oh, you're going to numb them so much, then they'll hurt themselves with sex, vigorous sex or something. But no, they can feel. And then I had one patient come back during the study. She was already having great success. She mentioned it to her oncologist, and he said, oh, well, that lidocaine, it must really be wonderful for your husband, but why, how could it be good for you? And she didn't want to contradict him, but she sort of came back to me and said, doesn't he know the difference between the clitoris and the vaginal opening? I mean, yeah, they know just where to put it, and it works great. In fact, I had women doing their little diaries, and one would say, okay, the number of exclamation marks is the number of orgasms I had in that session of wonderful sex with my husband. So
that's awesome.
Yeah, you reduce the pain, and then the enjoyment and the interest and the quality goes up.
I think I had, early on, I had one young patient, she was in her 20s, that had vaginismus that I gave lidocaine to, and she actually ended up going like with rebound pain. But I mean, that obviously is a wrong patient population, sending them to pelvic floor, working through that. But I'm excited about, doing more of that in my practice. I also am curious, what I've been interested in looking at is maybe doing a study looking at estrogen versus estrogen and testosterone at the vestibule, because I don't prescribe a lot of testosterone estrogen combinations, but I know some of my colleagues do. And I don't know if you guys have, anecdotally thought about that, but I've always been curious. If I feel like the estrogen alone could probably do more than the estrogen and testosterone for this patient population. But
yeah, I've been very wary of the enthusiasm about using men's hormones for women, I frankly have to say. And I feel like the studies there are those using both ENT for premenopausal vestibulodynia. I don't feel like the results are very convincing to me. So no, I haven't really added testosterone in that setting, but also not postmenopausally.
Just to play the devil's advocate here, the ovaries do produce some testosterone, and so it isn't just a male hormone. But
No,
I
I
haven't,
realize that, but the amounts of it.
yeah,
Yeah.
got it. So in the interest of time, we could talk about this for a really long time, but we have other things we need to move ahead to. So I'm going to start now with Dr. Mauskar. I understand you've been looking at the vaginal microbiome and postmenopausal women with lichen sclerosus. Please tell us about this. Can altering the vaginal microbiome help these patients?
Yeah, so this was a really exciting study that we just concluded, and we're in the process of looking at all our data. But we actually looked at the vulva microbiome and the vaginal microbiome, but focused really on the vulva for these patients, looking at different sites of. We had 6 patients with vulvar lichen sclerosus and 12 postmenopausal control patients. And we took microbiome samples from the clitoris, interlabial sulcus, labia minora, perineum, and then in the vagina. And so what we found is in the and again, small numbers, small samples, but it's very expensive to run a lot of these studies. So we found in the vulvar lichen sclerosus group, there was actually less diversity on the skin, alpha and beta diversity at the interlabial sulcus compared to postmenopausal women without lichen sclerosus. We also found that the vulvar lichen sclerosus group had lower levels of Candida glabrata, which has always been really interesting to me because I've been of the believer that a lot of times Candida glabrata is there and along for the ride, but may not be, necessarily contributing as much to some of the symptoms, although it can. And so I thought that was really interesting that most of our postmenopausal women without symptoms had Candida glabrata there, but it was lower in the vaginal lichen sclerosus or vulvar lichen sclerosus group. So, we have a couple of layers of analysis to do, but it was really interesting that the interlabial sulcus is where we showed that significant difference across multiple different families. And then after treatment, so we looked at all these women that were treatment naive. We followed them 10 to 14 weeks later after local steroid treatment. And most of the diversity in vulvar lichen sclerosus actually increased, so closer to levels of postmenopausal women. So again, lots of things to look at in the future, but that interlabial sulcus site was kind of the one that showed the most significance between the two populations. And so for people doing research in the future, that's one area maybe to focus on.
Can you clarify? Did
Yeah.
you say who had the lower Candida glabrata, the controls or the LS?
The LS groups so had lower Candida glabrata than the postmenopausal women.
It's fascinating.
Yeah, I mean, like I said, we're still kind of analyzing a lot of our data, but I think there's a lot to be said. And as far as I think that right now it's all the rage for vaginal probiotics and vaginal looking at vaginal treatments in this sense, and at least in skin disease. So for instance, in hidradenitis suppurativa, as well as eczema, we do show that disease states have lower diversity of microbiome states, just like we found with the lichen sclerosus. But as far as like novel treatments, I don't think we have all the data right now to show that if you do vaginal probiotics, you're going to have a sustained response. I'm curious on Pedro's thoughts about this too. But as far as skin disease, we know, there's been a couple of studies with psoriasis and hidradenitis suppurativa, and doing, I have patients actually just do kefir if they like yogurt, because it's inexpensive. The marketing for our patient population, we all know, is insane to have, the wash and the $100 vitamin you can take. But I think kefir, if you enjoy that fermented yogurt, just can increase the overall diversity in your gut, which we know is linked to skin. So that's what
ingesting the kefir or putting the kefir in the vagina?
No, please don't put it in the vagina. No. We I'm sure you guys also have your charts and the photos that patients bring in of what the discharge looked like after you put yogurt in the vagina. Oh boy. But no, definitely just drinking that. I think kefir, I call it kefir, but Just curious y'all's thoughts, I guess, on this topic, because I think it is a hot topic. And I work with a lovely collaborator here, Dr. Harris Tryon, who's just a microbiome gut guru and a hormone guru. And it's been a lot of fun to collaborate. But curious y'all's thoughts on things.
Let's hear Pedro Vieira Baptista's thoughts on this.
Well, I think we have a lot of wishful thinking concerning microbiome and probiotics. I think we have imagined that the normal is having lactobacilli, and if you don't have it, you put it there somehow, and things will just work fine. I think it probably is true that at some points in life, women definitely need the lactobacilli, especially during pregnancy. But we are not worried that children don't need lactobacilli. We are not worried that postmenopausal women, as long as they are symptomatic, they don't, most of them won't have lactobacilli. And my thoughts, and the interesting thing is that there are at least a couple of papers showing that women who have bacterial vaginosis type microbiota during postmenopause, they are doing better than the ones who have less loads of bacteria. So I think things are much more complex than we actually imagine. And I like to tease people saying, in a lot of aspects, it was also in this one, women are unique. We don't see this phenomenon of lactobacilli dominance out of pregnancy. So there must be a lot of things we don't know in this field. The other thing is that while, as you were showing, diversity is the normal, it's the desirable thing in nature, except in the vagina, in which you want 1 or 2 species of lactobacilli to dominate. So I think we are reaching the point in which we are about to assume that we really don't know anything about this.
Well, that leads me to our next question. This is for you, Pedro. A patient I just saw recently had undergone 8 laser vaginal rejuvenations and swears that this has saved her marriage. What are your thoughts on laser vaginal rejuvenation?
Well, first, when we are calling it rejuvenation, I get immediately scared if someone is saying that they are treating atrophy, and I'm not a fan of genitourinary syndrome of menopause definition. I still use vaginal atrophy and atrophic vaginitis, and I think with a microscope we can call it different things. I don't know what we can do differently, but I think we should investigate that. So, well, my concern is that we have good options to treat vaginal atrophy. They are available, they are safe, and they are cheap. Our biggest concern would be the group of women with breast cancer, obviously. And the interesting thing is that in the papers in which the studies concerning laser and radiofrequency, we see usually early in the first paragraph that estrogens are contraindicated in women who have breast cancer. It's usually a strong message to start with. There are a lot of studies currently about laser, and a few very good studies at a basic level, even a study in use showing no effect at all from the young depressed group in Belgium. We have had good papers, including the one published last October in the JAMA, which led to an editorial saying it's time to stop, but no one seemed to stop. And we still see a huge number of studies coming out without the proper design, without the control group, with the control group, small series, heterogeneous populations are to draw conclusions from that. But we see evidence, not so good evidence, not to say bad evidence, still growing that field, while we are choosing most of the time to ignore the good evidence. One of the important thing of having, I think probably we should ignore most of the studies without a control group, because there's a huge placebo effect in these studies, including sexual function, and it can be, that effect can be as high as 70%, as has been shown. Well, maybe, and we can assume that sometimes for these women, they are paying a lot of money to do this treatment. So they definitely expect it to work. They don't expect it to not work. Maybe it will break the cycle. Women who are not having intercourse due to fear, they have invested, they have somehow stimulated the vagina by introducing those probes. They felt probably some moistening due to the burning effect. They resumed intercourse, and as we know, women who have more frequent intercourse will have less atrophy. So probably it is just breaking that cycle. But they could probably be doing that without spending all that money using this kind of treatment, and probably that's what we should be saying to women. I'm currently not recommending. I would like to see good quality investigation in women with breast cancer. What I think, even if there is something useful in this technology, probably it will be lost due to it being used for atrophy, for incontinence, for vulvodynia. A couple of weeks ago, I saw it being recommended for, a 32 or 33-year-old woman being recommended for recurrent candidiasis.
Oh,
So
goodness.
I think it's absolutely wild. I think it should be looked into carefully with a scientific eye, but at the moment it's a wild thing, a very commercial thing, and in the end we will start to see the complications, and probably it will end up like the meshes for used in urogynecology. Probably it will end up just forbidden, and if there was something good that could be taken out of it, probably even that will be lost. My very personal opinion.
Well, thank you.
Echoed 100%.
I agree too. Yeah.
I will say, like, I muse about this, and it's not like I'm going around recommending laser in my practice, but it's very interesting to me, the placebo effect, because we know the more expensive things are, the more invasive they are, the stronger the placebo effect, which is in and of itself pretty powerful, and it's telling about, mind over matter in certain circumstances. But for sure, it feels unethical to recommend something that's going to cost a patient thousands of dollars and potentially put have the risk of harm associated with it. And in breast cancer patients where you really want to use it because you want to just circumvent the discussion of hormones, the evidence isn't there. And there's a sham controlled trial that came out in women on aromatase inhibitors, which I think you had just mentioned. And there's no difference.
I try to get them to take that $2,000 and go on a vacation or enjoy quality time with their husband or partner. And, then, really invest that time into that instead of, and if they want to do studies and it's free for them, that's one thing, right? To look maybe further. But I think at this point, guys.
And there's also we don't know the outcomes and the complications on the long term. We know that immediate complications, I think we can assume it's a very low rate, but we don't know the long-term effect of all these burns in terms of nerves, in terms of the bladder. We don't know whether after repeated course, because most of these women, they will be recommended to repeat it in 1 year and the other year and the other one. So they will probably end up with a lot of treatments, and we don't know the consequences of these in the long term. Maybe nothing will happen, but we cannot assure women that it's absolutely safe in the long term.
Well, again, this is another topic I think we could talk about for an entire hour. So we don't have a lot of time left, and we want to get our questions and answers out there. So what we're going to do now for you as an audience, we're going to show a quick video as we organize your questions. So type them in. We're also going to quickly discuss in the Q&A session some lichen simplex chronicus and lichen planus things, just so that we get that into your vocabulary. If you're not already seeing this patient population, how to treat them. So let's go ahead and get our Q&A going, and we'll listen to and watch a quick video.
Dr. Haefner, you can go ahead with the first question if you're ready.
Okay, great. The first question, I just wanted to quickly address lichen simplex chronicus and how you are treating that in patients with the itch, scratch, itch cycle. If any, Emily, do you want to address that or?
Sure, and I actually would be curious to know what others do in this circumstance. LSC is an itch scratch cycle that can be provoked by, say, a yeast infection or by a contact irritant of some kind, or insidious onset. It really can be non-specific, but a patient gets stuck in a cycle of re-traumatizing the skin that is itchy, and the key is breaking that cycle so the skin can heal and reduce the itch transmission, the itch signal transmission that propagates the scratching. And in menopausal patients, my approach is the same, where once I've confirmed that it's LSC and I remove the contact irritants and talk to them about vulvar hygiene, I add a topical steroid to try and reduce the amount of trauma and to reduce the urge to scratch. And I will occasionally layer in an oral antihistamine of some kind at night to try and really bring that urge down. Where I actually am curious about is, when do you add in the topical estrogen, if at all? Because I think that I usually lead with the topical steroids. And once I've talked to them about the vulvar hygiene, they leave with this, like, their brain full of all these things to try. And I hold off the topical estrogen because it's one more cocktail. So I layer things in visit by visit, depending on how they're doing. But I'm just wondering if anybody else has any tips or tricks about how to introduce it in a way that encourages uptake.
That's what I do. I wait a lot of times for the estrogen. And, I think that for a lot of these patients, I think where often patients come in with the right diagnosis and the right treatment, they're just afraid to use it long enough. So I have patients that come in and, I use a little bit more triamcinolone than clobetasol or mid-potency steroids, depending on where the LSC is. But, daily to twice daily for a month. If it's really thick and they're waking up at night and scratching and they're bleeding, I'll do it twice daily for 4 weeks, then once a day for 4 weeks, and then stop. And then I typically bring them back. And if the itch keeps them up at night, that's when I will add that topical. If they're not dermatographic, I don't always add the antihistamine, because especially in the postmenopausal patients, it can have the anticholinergic effects. But I mean, cetirizine, I think, is good, Zyrtec. But if they're not dermatographic, so like if you scrape their skin and they don't get like a response, then sometimes it's a different type of itch. And so that's when I layer in like gabapentin or sometimes Cymbalta as well for the anti-itch component. And then just like you, I tell them, sometimes there's more than one thing going on. We have to correct all of them to get to goal. So I'll do that layered approach. I'll target the LSC first, I'll bring them back, and then go into adding the local estrogen inside the vagina.
So Melissa,
that's
go
the
ahead,
only
Pedro.
time a vulvologist looks like a great doctor. That's the only patients you get well in a couple of weeks.
We have a regimen we use that has 12 steps to it, and we circle it and give it to the patient and have pre-written, scripts for everything. And they come back smiling, I'd say 85 to 90% of the time. Some people have been scratching for 4 or 5 years. Yeah. And I got that from the dermatologists.
Yeah.
They've taught us so much about the vulva, which leads me now to Melissa, a quick question on lichen planus. Your suggestions for patients that have early lichen planus in the vagina.
Yeah, so I, when it's vulvovaginal LP, I like to start with local steroids, either the compounded cream or just the anusol suppositories. But then the dilator use, I feel like it's very important to make sure they don't develop more adhesions. And so I don't always jump immediately to surgery or recommending surgery for those patients, depending on where they get it. If they're early on in their course, then I'll just do the local steroid. If they're postmenopausal, adding in the estrogen, I think is important, and then the dilator use. A lot of these patients also have vulvar disease. And we all know that sometimes those erosions are persistent and it's very difficult to get them treated. And so that's where, intralesional steroids can sometimes help. But I get a lot, I'm sure you guys all get a lot of patients that come in and, they're diagnosed with vulvovaginal atrophy or GSM. And then you look at them. We had a patient the other day that actually was like, well, there is some atrophy there, but I think that the erosions and the dysuria they're having are probably from the LP, and that's when doing those biopsies are helpful.
And what other thing can you look at in their body to diagnose LP?
Yeah, I
or soft-
often look in their mouth, and I think looking at the mouth can sometimes be confusing unless it's that beautiful Wickham striae that, you know, smacks you in the face on the buccal mucosa, because sometimes a lot of people actually suck and grind their teeth at night. So a lot of them will get this Morosio buccadorum right at that crease. But if you see the white Wickham striae, and then a lot of patients actually have gingival erosions. And so they'll be red and they'll be like, oh, my dentist just told me to come in more for cleanings. Dentists are often actually very good at diagnosing lichen planus. But mucous membrane pemphigoid is actually something that can mimic lichen planus. And often that has those gingival erosions in the oral mucosa. But those are definitely keys. Looking at the hair can also help, because a lot of people have lichen planopilaris.
For those of you that are seeing patients with extensive scarring of their vagina, we do a lot of releases of the scarred lichen planus, followed by insertion of a dilator that's sewn in with a Foley catheter in place for 48 hours. And then we get them on long-term high-dose intravaginal steroids with a gradual decrease, long-term steroid maintenance. So if you have a patient that you're thinking of operating on and need a protocol, feel free to email me, and I'd be happy to send you our latest version of the protocol we're using. My email is hafner@umich.edu. Next question. What are the hyaluronic acid moisturizers you recommend?
Oh, well, that'll depend on the country that you're in and where you're prescribing. Like, for instance, in Canada, the brand names that I'm pointing patients to try are things like Repagyne, Replen, Zestica. That one of those doesn't have hyaluronic acid, it's a polycarbophil base, but those are the three that usually I'll ask patients to try. And we give them a little table and a handout that they can take to the pharmacy and see what suits them.
On a similar note, someone's asking, why don't you add an estriol preparation into the hyaluronic moisturizing compound? It's been proven that there's very low serum titers and compliance is good. It's a recent product. Go ahead.
I think that goes to what Pedro was saying, where the estriol is available in Portugal, but it's not in Canada. You'd have to get it compounded. I try and give patients a cost-effective option. Compounding is very expensive. Mm-hmm. So I'll lead with what's available in the pharmacies, and then adapt if someone's got very sensitive skin, because like Repagyne, I think, has, tea tree oil in it. And if someone finds it, tea tree oil is not ideal for the vulvovaginal environment, but most people don't notice it, for instance. I'll adapt my approach if someone comes back and has very sensitive skin and
do you see a huge advantage in using Bresterone?
Can you
Sorry,
repeat?
was that
Bresterone?
Yeah.
Is that, can you define the compound in that?
No, it's actually
that's the
DHEA.
DHEA.
Yeah.
Okay.
We
I
have
don't use a lot of it myself.
We have it available. They say that the effect is only inside the cells, so that there is no absorption. But the studies show a small, and it has both estrogen and androgen effect, which could be an advantage even in terms of nerves. There is a claim that it improves sexual function, which at the same time doesn't make sense with the claim that the levels of hormones do not increase. I think it's an interesting option. I don't see it as a much superior option to estriol or estradiol, but I think and apparently there's also the claim that it probably might be maybe a safe option for breast cancer, but still no large studies available so far.
Yeah, we just have a study of Dr. Bouchard's, I think, is a pilot study of 10 patients that does show that there's no on aromatase inhibitors. So in the patients who you'd be very concerned about giving estrogen, more cautious giving estrogen to. But it's not robust and we don't have long-term safety data. I will say the patients I've talked to about it seem more open to trying the DHEA than they are to trying the vaginal estrogen. Mm-hmm. There's a subset that if I explain the physiology of it, they're more comfortable taking that intravaginally than the estrogen if they're on an aromatase inhibitor and know that it's not going to be synthesized into estrogen, and that its own the efficacy is through the testosterone or the androgen receptors that are also there.
Here's a really interesting question that we didn't address. We had it in a preliminary version of some of the questions I was thinking of asking. Is there any evidence for platelet-rich plasma for treating localized vulvodynia?
No.
No, I don't know.
No good.
There's some nice
evidence
placebo studies, because I also think that, or at least one I can think of, where there was like no difference than placebo.
What do you recommend for, go ahead, Pedro.
No, I was saying the same story for lichen sclerosus, which there has been also has been proposed as an option. And while small, low quality studies show it, better, larger studies haven't proved any improvement.
What do you recommend for patients that have difficulty with orgasms? Specifically, it is taking longer to orgasm since menopause. And would cystic fibrosis in this patient be a cause of this?
Well, I'm a strong advocate of referring patients to sex counselors, because I feel like, there just is not a one, there's not a one cure kind of thing. Women's sexual responses are complicated. There's a lot of history behind those. There is some hormonal, there's a hormonal effect, but it's very variable. There are women who have no problem with no estrogen levels and others who say that's a big difference. So I feel like a counselor is going to be able to get at a lot of those specifics of the person's situation and complaints.
I wish we had more sex counselors.
I think we should refer them, but we can tell these women that they should take the focus out of the orgasm. It should not be part of her focus. I usually tell them, as if it is your focus, you won't reach it. You will be close, but it will take long. You won't be able. But indeed, I think it takes a lot of time and working, and it's beyond our capacities, at least mine.
So we are lucky to have two sexual counselors in our clinic, and they help this population very well. They see our new patients, and they're very educational. They use a lot of vibrators, some that hit the G spot, if you believe in that, or the A spot, and new spots that develop every week in the vagina. All right, in the interest of time, I'm going to just say some final words. We didn't get to all the questions. I apologize. There are lots of wonderful questions out there. I want to thank all of the panelists for your participation and all of you in the audience for this discussion. It's been excellent. Please remember to visit our website, www.issvd.org, and consider joining us in the 27th Biennial Conference in Chicago this September. Also, do consider joining us in September 2024 for the World Congress in Slovenia. If you've not already downloaded the vaginitis guidelines, be sure to use the QR code to assist you in downloading the recommendations from the ISSVD on the diagnosis and treatment of vaginitis. If you miss it, it's available for free on our website too. Finally, if you want to join the ISSVD, go to email us at issvd@issvd.org. And somebody wondered about my email address that I had mentioned. It's HAE as in Edward, F as in Frank, NER@umich.edu. Thanks and have a wonderful day. Thank you for the participants and thank you for our speakers.
Thank you as well.
Thank you.
Thank you.